which is going to be made by Dr. Raj Prasad, who is again an SCPGI alumnus, who was for a long time at the University of Leeds as the HPB and transplant surgeon. He had a brief stint back to India, but then went back, and now he's moved to Milwaukee to probably establish, am I correct, Raj, to establish and start a transplant program there?
No, we already have a transplant program, but the direction of travel needed some change, and they wanted some new ideas and new way of doing things. So yeah, that's why I'm here.
Good. Yes. So Raj is going to tell us what will be the algorithmic approach. Am I correct?
That's what you asked me, Dr. Kapoor, but
yes.
How do I share my slides? No, thank you, Dr. Kapoor. And I really enjoyed the earlier presentations, and compared to them, I feel grossly underprepared for this because I have only 4 slides, of which one of them is the title slide. You wanted me to talk about an algorithm. One thing I've realized is as I grow older, I begin to think more simpler and in much more simplistic terms, and probably it's a marker of self-preservation, unable to keep up with the next generation coming with so many ideas and thoughts. And we love our algorithms, especially in when I was training in India, we were very much not just the practical experience, the theory aspect is so important, and we like the idea of being able to group everything into a line diagram and have outcomes and conclusions. But I realized actually, it's nice for academics, but in real life, and I borrowed this line from a book I was reading recently, in real life, there is a difference, a big difference between what one can propose and what one actually does. So I thought I'll keep it short, and I'm happy to answer questions as we go along. So what do we do with a liver SOL? It depends on so many things, and I thought, how do I approach this in my clinic if my fellow or resident comes and says, this is what we have, what do we investigate? How do we investigate? And I think it depends on probably the 3 key things that come to my mind while I make the decisions. One is, what is the context of the finding of the liver lesion? Is it incidental, or is it something picked up on surveillance, or someone had symptoms? Second is the patient demographics, age, sex, because you probably heard yesterday, there are groups of benign tumors which are much more common in women in a certain age group, and if you find something, a benign looking tumor in an older male, you probably tend to look at it in a different way and pursue it in a different algorithm. The third factor I would think is what are the risk factors? Is this someone who is on pills? And again, the whole benign liver tumor, especially the adenoma story, and again, an increasing number of adenomas, multiple adenomas we see in young women with metabolic syndrome, and also who are obese and morbidly obese. And then, do they have chronic liver disease? And equally important, is there a history of previous cancer? And in surgical practice, obviously, history of a previous colorectal cancer makes a huge difference because that's one area where we tend to get interested in. So I tried to group those scenarios into few of them, and there'll always be exceptions to this. So if you find a young or youngish patient who's a female and has multiple liver lesions, you think it's likely to be statistically benign liver tumor is the most frequent reason, and you go down the route of MRI. If this is someone with risk factors for chronic liver disease, which can lead to both HCCs and also to intrahepatic cholangiocarcinomas, then your thinking goes to, okay, I'll do a liver MR to know what is the type of the, what is this lesion, LR1 to 5 to LRM. And by the way, in terms of biopsy, when we were talking before, I tried to add that I think the only reasons we biopsy are the groups which are LRM, trying to understand if they have a cholangiocarcinoma, are they cholangiocarcinomas or just purely HCCs. And in patients who are not for curative treatment before any systemic therapies, we biopsy them. So an intrahepatic cholangio is a whole different ballgame where the immunohistochemistry is so important for targeted treatments. So once we do an MR, we also do a staging CT. And if it's an intrahepatic cholangiocarcinoma, nowadays it's not a disease of exclusion at all. It's actually a disease, you identify the imaging characteristics quite well, and often you diagnose that from the imaging. And we tend to do a PET CT as a routine, and we look at the tumor markers to understand whether they would help in management algorithms and understanding biology. Patients who had previous primary cancer, especially a colorectal cancer, you find multiple liver mets. We do a liver MRI because they may be candidates for resection either straight away or after neoadjuvant downstaging chemotherapy. We also do a staging CT. Other primary cancers, we often in our tumor board, we end up seeing increasingly, especially post-pandemic, with some of the primary tumors, like unusual tumors like nasopharyngeal cancers, presenting much later, presenting with liver metastasis, they get sent to the tumor board. And most often there's no point, there are no liver directed treatments for them. So when you find these tumors, what we do is just a staging CT and biopsy them. And the tumor markers we tend to use for especially the colorectal liver mets are the CEA, and CA19 is also occasionally helpful. And then the other scenario you get is multiple tumors, and we know from the CT it's likely metastatic. Someone picked up incidentally or maybe for symptoms. What do we do them? No known previous primary cancer. So you do a top and bottom scopy and and often here we use PET CT if the scopies are negative, to see if there's another underlying primary that lights up, and if it's still uncertain, we biopsy. But one thing I come to realize is, as a youngster being trained in SGPGI and PGI, I used to remember all the differential diagnosis and all the weird and wonderful things. But then you realize common things are always common, and I think your approach should cater to that. But there are two diseases that often surprises me, even as a liver SOL. It's the good old TB. It's nothing good about it, but the tuberculomas. We have seen and resected some tuberculomas thinking they're tumors, and also lymphoma. So these are two things that come to my mind that they can surprise you once in a while. And one area where we are particularly concerned and try to do more than what we would normally do as an investigation, if necessary, biopsy or resection, is this atypical FNHs in adult males, because some of them we had a bad experience and turned out to be malignancies. So we take a bit more of all the benign liver tumors. That's one area where we take a more aggressive approach. So when in doubt, you either biopsy or resect, depending upon the risk benefit, whatever is appropriate. So that's a very simplistic way, but that's my approach to liver SOLs, and I'm happy to take questions.
Yeah, good that you left a lot of time. So I have some questions which I actually wanted to raise yesterday, but yesterday we were running quite tight. So I'll put them one by one, and if you could give practical answers which can be used by those who are watching this and who will be watching this. So on ultrasound, we see a cystic lesion, and the radiologist says that it is a simple cyst. But yesterday, the radiologist said that some tumors can have a cystic appearance. So what would you do? Would you leave it at ultrasound, or would you further investigate every cystic lesion?
So one thing we tend to look at is this patient had an ultrasound 5 years back for something else. If they had an ultrasound many years back and they said they had a cyst, and even if it's increased by 1 or 2 centimeters, it's a simple cyst. So prior radiology is useful. If there's no prior radiology and you see cyst for the first time, you would, if there are 3-4 small cysts you've seen in a liver, then it's likely to be simple cyst. But if you see only one cyst and a large cyst, it's again statistically likely to be simple cyst, but I do a cross-sectional imaging. So it depends on whether there's prior imaging or not. And I do a cross-sectional imaging, and if it confirms it to be a simple cyst and asymptomatic, we don't do anything else. The only ones where you'll get concerned is atypical features like septations or thickening in a wall, and even in them, we still tend to offer resection to atypical cysts, and more than half of them turns out to be simple cysts.
And if you see a solid lesion on ultrasound, would you always do a cross-sectional imaging?
Yes, we always do a cross-sectional imaging, and the context is that's where you find it in someone with a cirrhotic liver or an abnormal-looking liver. You go to a liver MR, and you find it in other contexts. Then you do a CT.
Between CT and MR, which one will be the first?
It is if you know you're dealing with a primary liver tumor. Or it's the benign liver tumor context, young women, multiple lesions. I go with them. We go to MR. If you think you're dealing with a metastatic tumor, then you go with a CT, especially a staging CT first. And in the colorectal context, then you do a liver MR. If you think there could be surgical options.
Any tips not to miss a biliary cyst adenoma, misdiagnosing it as a complicated cyst or a hydrated cyst?
I think it's over-treating them. That's the only way you don't miss a biliary cyst adenoma, is over-treating anything that's looking complex with resection. So, as I said, more than half of these lesions in our practice turn out to be simple cysts, but it is in that scenario of not wanting to miss a biliary cyst adenoma, and we had burnt our fingers in the past with trying to do a wedge excision, the fenestration of operation or the deroofing once, definitely, which ended up in a bad outcome for the patient. So yeah, as long as the risk benefit of what you're advocating justifies that approach. If someone who is 80, asymptomatic, even if you have a bit of doubt, you don't do anything.
Ultrasound shows a hyperechoic lesion. Sonologist says it looks like hemangioma. But again, yesterday, the radiology colleagues told us that other tumors can also be hyperechoic. So would you stop at that, or would you do a further imaging?
A liver MR. Yeah, it's so important to part of it is defensive medicine.
Do you use isotope scintigraphy today to confirm that it is a hemangioma?
No, and I think liver MRI is very good.
Unknown, a liver metastasis proved by FNAC, unknown primary. Is pan endoscopy today the first investigation, or straight away we can go to PET CT?
We tend to do an upper GI and lower GI endoscopy, and because it's the commonest site is somewhere in the GI tract, and we do that. But if that is negative, we go to PET CT.
Solid lesion.
Yeah, please go ahead.
Solid lesion and the tumor markers and imaging are not helping us, but it is resectable and you are planning a resection. Would you do a biopsy or would you straight away go for resection?
I would go for resection if we think it is resectable and the risks are acceptable. Then we go for a resection.
But for transplant, you will always do a biopsy.
For what, HCCs?
No, suppose the imaging and tumor markers are not telling you the point which Bala was making, HCC versus intrahepatic cholangio. Before doing a transplant, would you insist on typing the tumor?
Yeah, so it's the context is a chronic liver disease context with a liver tumor that fits within transplant criteria from size and number, but not necessarily in the imaging characteristics. So we would call it, that would be LRM. You suspect malignancy, it doesn't look like HCC, it's LRM. So for LRMs, we biopsy. And also what is interesting is that sometimes you see an LR5 and an LRM. And again, we end up biopsying the LRM. We don't assume that it's definitely HCC because there's another lesion that definitely looks like HCC, but we end up biopsying the LRM. And more often than not, especially if there's another LR5 lesion or LR4 lesion, this turns out to be HCC. But there is an occasional one. It turns out to be an intrahepatic cholangiocarcinoma. And again, now we have protocols where if it's less than 2 centimeters intrahepatic cholangio, we transplant them because of the data that their outcomes are as good as HCCs. But anything more than 2 centimeters, we don't. And the worst one is the mixed combination.
The next question, either you can take or Dr. Saraswat can. So cirrhotic, non-cirrhotic, what is the surveillance protocol for HCC?
I think it's a changing field. Probably not in cirrhotics, but I think it's appropriate that Dr. Saraswat answers it because it's their patients we operate on. So I respect that.
See, I think all the guidelines still go with 6-monthly ultrasound and alpha fetoprotein. Nobody has recommended in the general public at the high risk group any other protocol except in the transplant waitlisted patients. If people are listed for transplant and they're on the wait list, then people would use triple phase CT scan to surveil them, because the moment you pick up an HCC in a person not earlier diagnosed, his transplant status changes immediately. So, and that surveillance. Now, the other newer markers, none of them have really reached. There are a lot of potential combinations and approaches depending on what patients you are dealing with. But I don't think there's a consensus yet to have reached the level of guideline recommendations for surveillance. I mean, a major problem is HCC developing in non-cirrhotic livers, which happens increasingly we are seeing in fatty liver disease, as well as in a subset of patients with chronic hepatitis B. And really, at present, there are no very effective surveillance strategies for these subgroups.
Dr. T.D. Yadav from PGI Chandigarh has raised his hand. Dr. T.D., please come.
Namaskaram, Prasad sir. This is TD here. I was listening to you. Just you said PET scan, and just because PET scan, to our understanding, has a limited role in algorithm of the SCC. But certain newer isotopes are coming. So can you please elaborate a little bit more, because you worked in such a high volume center. We think that because of the metabolism of the glucose, it has role in algorithm is a little bit limited. So
thanks, TD. I agree with you that in primary cancers, apart from intrahepatic cholangiomas, we use PET-CT to exclude extrahepatic disease. HCCs, only a third of them, as you know, has an uptake, and those which have uptake are usually the worst biology tumors, but we don't use that as a routine. The place where we use PET scan is this adenocarcinoma, unknown primary, and you want to know the endoscopies are negative. You want to know before you biopsy, is there another lesion you could pick up? Could be the primary. So that's the one situation we use. And I know there are newer, apart from FDG, there are other PET modalities. And I was talking to some of the colleagues at AIG recently, who are involved with the PET scans there, using for biliary cancers and other, and even I think HCCs. We don't have access to any of that. In some ways, India is technologically more advanced than what we have. I know Dr. Kapoor is laughing, but that's true. And so I have no experience with using other agents for PET.
But Raj and Bala, is it not that some groups would use PET to exclude patients for transplant? As Raj was pointing out, that if the HCC is avid, then biologically it is likely to be aggressive. Am I correct?
So regarding the FAPI, we use FAPI PET. It's a fibroblast activation protein, not FTG. We now completely incorporated that into our routine algorithm.
I think you have published also.
Yes, that is the first publication from India in HCC. So we, in intrahepatic cholangio. So we tried in HCC also. It's quite effective in intrahepatic cholangio. So it's almost 30% difference is there between the FDG and FAPI. The only thing is it is availability a little bit constrained sometimes. So we cannot use it. The essential reason is this FAPI basically targets the cold tissues. It targets the cold tissue because cholangiocarcinomas are literally fibrotic tumors. So it exactly targets the fibrotic tissue rather than the metabolically active tissue. This is going to be a game changer. That's what we feel. Yeah.
But the best marker of tumor biology is test of time. And I think that's what all this downstaging therapies, everything give is just weed out those. Dr. Saraswat was very right in the very beginning. They give you the ability to pick up who will get the best outcomes.
Sir, Dr. Raj, recently I managed two patients of child A and a little bit going towards child B, and they had SCC. So I was thinking that volume was lesser in it according to if you are going to right hepatectomy. So I thought let's do a embolization portal vein, and that will show us two things. If regeneration occurs, it will tell us that liver is okay, and if it after regeneration, if it is adequate volume as per defined criteria, then probably we will resect. And fortunately, in both the patients, we are able to do that. So, can you just give more detail about this idea? Because actually, as you know, our numbers are actually limited because, as Dr. Saraswat sir was saying, we get late patient. But this I thought, and probably maybe it's too less number. But once it gives a result, it gives an idea that probably we are at the right path. So,
yeah, thanks, TD. Every series starts with those small numbers, and that's how you grow. So I think that's good. What you're trying to do is part of I think most centers management algorithm. So I think resection in HCC and cirrhotics, the few principles I use is lesser the better. Lesser the extent of resection is better. The minimal access, it's better. Less bleeding, it's better. So I think these are some of the important factors that would help in choosing resection. So no portal hypertension. is important, and we don't measure any wedge pressures, but there are a lot of teams that swear by using wedge pressures. The problem I have with wedge pressure measurements is that it's so much dependent on the positioning of the patient, and the same patient, two different IR radiologists, they can give you two different readings. So we rely on platelet count, presence of viruses on endoscopy, and the size of the spleen. ICG we don't do, but I think there are a group of patients who may show signs of portal hypertension, but good ICG readings, they could also be surgical candidates. And finally, the approach you've taken, testing the ability of the liver to regenerate by doing portal vein embolization, I think it tells you whether that liver will regenerate or not. And I use similar approach many times, and often it regenerates, and it's great. You go ahead with resection. The only caveat I have for this is sometimes after PVE, the liver doesn't grow, the remnant liver, and it always bothers me. And the same with PVE in colorectal mets. What bothers me is that could I have predicted this better by some other way, and have I done disservice to these patients by blocking their portal vein? And I don't have data. And just as I was leaving Leeds, I talked one of my younger colleagues into looking at this data, and he's still doing that. What is the outcome of patients where PVE, we have done PVE, it failed to cause liver regeneration? And what is the outcome with systemic therapy in these patients? Have we disenfranchised these patients by limiting their
Dr. Raj and TD, I think a basic point I'd like to get clarified. To my knowledge, PVE is done in non-cirrhotic livers. Cirrhotic livers, by definition, do not regenerate. I would be seriously skeptical of regeneration in a well-established cirrhosis.
We do PVE in cirrhotic, cirrhotic livers also with no signs of portal hypertension.
Yeah, I mean, but if it is you have histologically proven cirrhosis, by and large, most of them are very bad at regenerating. Any ablative modality they do not tolerate because the liver reserve is limited and their liver doesn't regenerate.
Well, it is those patients without portal hypertension, Dr. Saraswat. There are a group of patients where, despite it took us time to convince hepatology colleagues and because rightly they're skeptical just like you, but
and you have documented that there is regeneration.
Yes, of course. Yeah. So
I was also going to ask that point, that you've done portal vein embolization. Unfortunately, it doesn't atrophy and hypertrophy. Now you are not resecting because you think it is not going to do well. So what is the harm done to the patient?
Yeah. I think that's what bothers me. I don't have actual data, and I tried to look at literature to see if something would help me. Not obviously, we have a lot more patients with colorectal mets who we did PVE, didn't progress, and I think that's an easier group to study. Yeah. But it's a theoretical bother because of the do the chemotherapy drugs have the same reach to the but I don't know.
And obviously, you would not do any hepatic artery based therapy in these patients.
No, only in US they do hepatic artery, and we do here now.
After portal vein embolization.
I don't know what they. I don't understand their practice yet. One of my colleagues very, very well, and he's quite big into hepatic artery infusion chemotherapies. But Clark, he was there recently.
Yes.
Yeah. So yeah. In UK we never did hepatic artery infusion.
So it's 8:30. We are into the next session. So Funny Krishna, you can come in because we are already in the open house discussion, but Funny, you can come in. Avinash, you wanted to ask something. I don't know whether I have already asked.
Can I just little bit
yes.
So but Saraswat sir's the concern and query. So this is the lead we got from our work on so-called secondary biliary cirrhosis when we got a neglected patients of biliary stricture. And we were after doing lots of work, we were to do biopsy liver and fibroscan test, and we find reversal in many of the cases up to the this fibroscan LSM report of even more than 40. And these patients are, as Dr. Prasad was saying, no portal hypertension at all, and their platelet count was this thing, but they were hepatitis C. Both these patients were hepatitis C positive, and they were on the surveillance program, and still their liver showed. But yeah, it was child A. So that is how we have done it. And in the post-op, that's why I said in the beginning with the caveat that these are the patients we are number is very less, but that was the idea I got because patient was otherwise normal liver function and everything normal as we get in most of the patient early child.